and welcome to Treatment Zaruri Hai, a series presented by Merrill in association with Deccan Herald. And I am Sneha Ramesh, your host for today. In today's episode, we'll be discussing the implications of robotic and minimally invasive surgical techniques in everyday cardiac surgical practices. With the advent of technology and advancements in medical science, the options available for patients have increased significantly. Both robotic and minimally invasive surgeries offer a host of advantages, including easier post op recovery. However, it's crucial to understand where each of these fit and choose the right ones at the right time. To explain all of this, we have with us a panel of doctors from Bengaluru. Let me introduce them. We have with us Dr. Adil Sadiq, Senior Consultant and Head, Department of Cardiothoracic and Vascular Surgery, Sakra World Hospital. Welcome, Doctor.
Thank you very much, Neha.
Dr. Arul Furtado, Senior Consultant and Cardiothoracic Surgeon at Aster Hospitals. Welcome, sir.
Thank you for having me, Sneha.
We have with us Dr. Sudarshan, a cardiothoracic and vascular surgeon with over 17 years of experience. His areas of expertise include minimally invasive and robotic cardiothoracic surgery. Thank you for joining us, Doctor.
Thank you. Thank you so much.
Next, we have Dr. Thiruthani Kumaran, who is a highly experienced adult cardiac surgeon with expertise in robotic and minimally invasive cardiac surgery at Narayana Institute of Cardiac Sciences. Thank you for joining us, Doctor.
Thank you, Sneha.
So to start off this discussion, as I spoke about earlier, cardiac surgery today offers multiple approaches. I would like to ask Dr. Kumaran, how has this shift changed the way surgeons think about treating heart diseases?
Hi, Sneha. See, the shift has been progressively has been increased from the conventional cardiac surgery to minimally invasive and robotic cardiac surgery in the past couple of decades. The shift has been significant. Before, the surgeon usually asks the question whether how we can offer the treatment, but now the question has been moved what offers best for the patient. The shift has been more from the conventional cardiac surgery to the minimally invasive and robotic cardiac surgery, and even to the catheter-based intervention procedures for the heart-treated surgeries. So to begin with, it also has increased the concept of heart team approach, where we involve the cardiologist, anesthetist, intensivist, and highly decorated other paramedical people to involve in the heart team to take necessary steps to approach a particular disease for a particular patient. To bring about to concise in a brief manner, the cardiac surgery now it offers a tailor-based approach. For example, the one procedure is not fit for all the patients. So now what we do is what is good and what is best for the patient, we do that. So that shift has been seen in the past couple of decades.
Right. So when we say that it offers a tailor-based solution and a lot more flexibility and it has expanded the treatment options. If we are to see clinically, Dr. Adil, I would like to ask you, what clinical gaps have these robotic-assisted and minimally invasive surgeries aimed to address in the cardiac space?
So thank you for that, Sneha. Very interesting question, something that's posed to us by many of our patients. Very clearly, the gaps that are bridged are not just clinical, but sometimes also technological. For example, if you're doing a surgery, a minimally invasive surgery in a frail, old 80-year-old man, I would easily prefer to do a robotic surgery when there's less stretching, pulling, or pushing, or cutting of any bones, rather than doing an open heart surgery. Suppose I'm doing a surgery in a 35-year-old. I want to do a minimally invasive, and I want to take down both the arteries of both sides of the chest. Using robotic advances now, I can enter the right chest from a camera placed on the left chest and take that artery down as well. So something that we call bilateral internal mammary arteries. Suppose I want to take a tumor out of the heart. The vision that it gives me is 10 times as much to go right into the chambers of the heart, look at the muscles of the heart, and do a much more efficient and better job. So bridging these technological gaps are the clinical advantages that we have. Patients that I thought would not be fit for open heart surgery are now probably fit for robotic heart surgery. So there are a lot more other people who can gain the clinical benefits of all the technological advances that robotic surgery has to offer.
Right. So there's a lot of one patient group, many patient groups who are actually, reaping the benefits of this new technique. So when we say that, I would like to ask Dr. Sudarshan, in everyday practice, sir, how do this robotic and minimally invasive techniques truly change the surgical experience for both the patients and the surgeons? So how does it change?
So I think we have come a long way in the last 1 decade come from conventional to robotic and minimal access surgery. So it has given good experience not only to the patient but also to the surgeon. From the patient perspective, as you know, we don't cut the bone as in conventional cardiac surgery. We only go to the soft skin and soft tissue. So there is a less trauma to the skin and soft tissue, which results in a better recovery of the patient, faster recovery of the patient. Patient experience very less pain, very less blood loss during surgery. Patient gets out of the hospital in a very short period of time. In fact, the patient recovery is much faster compared to the conventional cardiac surgery. So from the patient perspective, it is a very good plus point. In addition, the complication rates of what we come across in conventional cardiac surgery is much lesser in the old and frail patient. That Dr. Adil mentioned, very old and debilitated patient. When we cut the bone doesn't heal properly in many such cases. So minimal invasive and robotic offers a very good advantage for these subset of patients, wherein the patient recovers faster with very less complications. So that's from the patient perspective. From us surgeons, we have adopted this technology because it gives us an excellent visualization. The robotic comes with a very high definition camera. So we can reach the structures of the heart wherein we were not able to reach by naked eye. We can see the intricate valve structures, the structures beneath the valves, and do a very complicated repair which are not possible by open conventional techniques. And in addition, as you know, in conventional surgery, we have to need to stand for a longer duration of hours. We need to stand next to the patient for a longer procedure. But now we are sitting next to the console. The surgeon's back and the neck is very well preserved. So the surgeon can increase the operative duration. So not only for the surgeon, for the patient. So I think it's a win-win for both the surgeon as well as the patient.
Right, sir, right. So when we know this techniques offer a lot of advantages, when we come to look at the heart diseases, actually, so I mean, it's a general perspective is that the arteries are blocked and all of it, but there are other conditions which are not talked about frequently, like valve stenosis and valve regurgitation, which are actually called the silent killers, and they're not spoken much also. So, Dr. Arul, why do patients with such conditions tend to present late, and how does that actually affect the outcomes?
I think that's a very important question that you're addressing, Sneha. You know, when it comes to cardiac surgery, everybody thinks it's about performing bypasses and things like that. But there's a significant portion of the population which is affected by this valvular heart disease. And there are about 4 valves in the heart. And the 2 of them are the ones we deal with majorly, something called the aortic valve and the mitral valve. And as cardiac surgeons, we are not the primary caregivers. Most of these patients are referred to us by other doctors, by physicians or by cardiologists. So there is a significant proportion of these patients who get diagnosed and mislabeled as non-cardiac conditions. You know, in my practice, I've seen many young people affected by a condition called aortic stenosis. You know, they have something called a bicuspid aortic valve. The valve becomes narrow with age, and they're mislabeled as, you know, adult onset asthma or recent asthma. And they just get treatment for that for multiple years together, and they come in with failure. And then they get an echocardiogram done, and then they are diagnosed with valvular heart disease. So I think we've been trying with various care groups to try and get the message out there that, you know, when a person comes with these symptoms, think beyond the lungs, look at the heart too. So one is primary awareness among that section of caregivers. 2 is a lot of patients, even once they're diagnosed with valvular heart disease, they just sort of fall off the radar. You know, we tell them, come back to us every now and then, get an echo done, see how your heart valve is functioning, whether it's deteriorating, because in the course of time, once the valve leaks more or becomes more and more tighter or stenotic, as we call it, it exerts some sort of effect on the heart. And at a certain point of time, the heart starts failing. And that's not the best time to go in and operate. What you're doing then is just salvage surgery. So if you get a patient who's diagnosed early with all his heart function preserved, that is the best time the patient can get the surgery. And like my other colleagues have mentioned, minimal invasive and robotic surgery was meant for valvular heart disease. I think in this day and age, anybody doing a valve by any other method, unless there is something really precluding this treatment option, that is the way to go. Minimally invasive and robotic for valvular heart surgery is the way to go. I think it just needs patient awareness, a lot of education, and getting the message out there that, try to listen to your heart when these things happen.
Right, right. Thank you, doctor. So when we are talking about valve stenosis and valve regurgitation, I would like to ask Dr. Sudarshan, how have the treatment options for these conditions evolved over the years, last few years? How have the treatment options evolved, particularly for these conditions?
Yeah, I think India is known for more what is the commonest heart disease called as rheumatic heart disease. Now, rheumatic heart disease affects the commonest valve called as the mitral valve. There are four, as Dr. Arul mentioned, there are four valves. So the mitral and aortic valves are the commonest affected valves. So when the rheumatic heart disease affects these valves, the patient suffers for many years without getting treatment. So even though there are medical treatment, they reach some stage that they need a surgery. And over the years, what we have seen that because of the fear of the conventional heart surgery, the patient do not get the surgery done. So in the last couple of decades, we have got new treatment options available, that is the minimal invasive and robotic heart surgery, wherein the recovery is much faster with the same surgery. We can do the valve replacements and even the advanced valve repair techniques using very, very less incision technique, like what we already mentioned, that minimal access and robotic heart surgeries. Earlier, in the earlier decade, almost all of these patients would have got the surgery through a conventional sternotomy. But now, by default, we offer these high definition surgeries through minimal access route. So what we have seen in the last couple of decades, now earlier the patient used to stay in the hospital for almost a week or 10 days. Now we have reached a stage wherein it can be offered as a daycare surgery. There have been instances where we have operated and the patient has got discharged on the next day. So that's how we have evolved over the last couple of decades. And of course, the results have become excellent in the last few years. It's almost to the reaching 99 to 99.5%. So that's how safe it has become, with the very less complications and with excellent results.
Right, right. So I think one point that all the doctors and have also been telling is that the robotic assisted or minimally invasive techniques have a lot of advantages and all of it. But Dr. Adil, can you tell us what real world advantages do minimal invasive or robotic surgeries offer, like beyond a smaller incision? What all other advantages do they offer?
Well, Sneha, that's the question that every patient asks himself or herself. So from a patient's perspective, the biggest advantage they see is this really dainty, cute, small incision. But cosmesis is only skin deep. And the advantages of minimal access and robotic surgery go way beyond that. We're talking about less pain, less need for blood transfusion, lower chance of infection, faster recovery, overall less need for antibiotics. All of these are the real advantages of robotic heart surgery or minimally invasive heart surgery. So much so that I can proudly say that these advantages have stood the test of time. 14 years ago, when I started doing robotic heart surgery, probably 5 or 10% of our patients would get this option. But technology has also advanced, patients' awareness has advanced, so much so that today, 95% of all our heart cases that we do at our institute are robotic or minimally invasive heart surgeries.
Okay, right. So when you say that there is a large shift towards use of robotic or minimal invasive techniques, I would also like to ask Dr. Arul, when we talk so much about robotic or minimally invasive, we also need to understand that they cannot completely replace the conventional open heart surgeries, right? So why do conventional open heart surgeries still remain indispensable despite these techniques gaining importance and advancements?
I think there are two parts to this question. All of us as surgical trainees, even when we were going through general surgery, we were taken through the regular, what we call the open laparotomy route, and then we moved on to laparoscopic approaches. Even in cardiac surgery, you get good at your regular conventional surgery, and then you move on to minimal access and robotic. The reason is twofold. One is there is going to be a subset of patients who might not be the best or the ideal candidate for minimal access / robotic surgery. And these are patients who have multiple other problems in addition to cardiac problems. In order to get a successful minimal access / robotic surgery done, you have to tick a number of boxes. You have to put the patient for a valvular heart surgery, especially to put the patient something called a heart-lung machine. So you got to have vessels which you can use to do that. If that's not feasible or those things don't work well, then you've got to go with the conventional method. And there are cardiac surgery is not just limited to what we call a bypass or valve repair or replacement. Sometimes you have multiple things to be addressed in the heart together, like 3 valves, a triple valve surgery along with a bypass. So that's when your conventional surgery comes in, and you've got to be a good conventional surgeon and have enough of expertise to get this done. It doesn't mean that you can just do robotic stuff. I mean, we've all gone through this. We've gone through this and then moved on to robotic and conventional. Then there are other surgeries like aortic surgeries, aortic aneurysms and dissections, which cannot be tackled through minimal access techniques. So there is a certain subset which can be tackled only the conventional way. And there's a huge subset which falls into the bracket of minimal / robotic. And finally, to come back to the thing which I came in the beginning, as surgeons, we've got to have bailout options if things, don't work out the regular way, when you're planning a minimal or robotic. So you've got to be a good conventional surgeon to address a situation when things don't go all right, So conventional surgery is going to stay. The proportion of conventional surgery is obviously going to come down. But the thing is, conventional surgery will not totally go away. You've got to be well versed in that too, because you have a small subset of patients which require conventional surgery, but there is a shift of most of the patients going for robotic / minimal access. That's the long and short of the answer.
Dr. Arul pointed out very well that not all patients might be fit for a minimally invasive or a robotic surgery. I've also heard a lot of you telling that selecting the suitable patient is also very important. It's a key to success. So I would like to ask Dr. Kumaran, what does that mean in practical terms? What are the check boxes that you would like to see, or how is it that you actually select in practical terms?
Good question, Snega. This is the most common question. Like most of the patients who come to my outpatient, they ask whether can I be offered robotic or a minimally invasive cardiac surgery? Yes, the patient selection is most. It might sound a little technical, but it's the most fundamental, and which chosen correctly and given properly, the outcomes are excellent. So when we say patient selection, we see the patient as a whole, not only considering the disease, what they have, we consider the anatomy of the patient, their physiological reserve, their comorbidities, their frailties, their physiological reserve, what they have. So we take everything into account and then we give the best option for the patients. It's not that two patients are having a coronary disease, both can be given a robotic or a minimally invasive approach. So one patient will be suitable for a minimally invasive or a robotic, but whereas other patient may not be suitable for a minimally or a robotic, where he will be much better off with a conventional sternotomy approach. So when we see we see the patient as a whole, And then like it's something like what I told initially, like it's kind of a tailor-based approach. So looking at the anatomy and like as even like Arul and Sudarshan told, it's not that like any patient who comes with a particular kind of a disease, yes, they have can't be given minimally invasive or robotic. No, it cannot be possible. So we chose the patient and we see patient as a whole, and then like we give them the best possible approach for that particular kind of a surgery. And even like Arul has pointed out, like when we do a minimally invasive or robotic surgeries, like we put the patient on a cardiopulmonary bypass machine where we need access for a particular vessels. So if those particular vessels are not good, and some patients when they need more than one procedure to be done. So in those kind of patients, like still like a conventional sternotomy is a gold standard. But having said that, the minimally invasive and robotic for a right patient and done well, executed well, the results are amazing. It's a real game changer. So choosing the patient is very important, especially when it comes to minimally invasive and robotic cardiac surgeries.
Right. So it's multiple factors. It's not just age, older people, younger
Yes.
people. So you see a lot of multiple factors to ascertain if they're good for which one suits them the best. So that's the key, I understand. So when we speak about patient selection and all of this, Dr. Sudarshan, one thing I want to ask you, out of your experience, what you've seen all these years, have there been situations where choosing a less invasive approach may actually increase the risk?
Yes, definitely. I think the last couple of questions, the patient selection is the hallmark. Any patient walking in that he wants a minimal access robotic surgery has to be screened by the operating team first before he is deemed suitable for a less invasive option. Just because the patient asks, you cannot go in for less invasive option, because some cases, as already mentioned, it may be much riskier, like if the patient's anatomy is not suitable, or patient comes in an emergency situation where saving the life is more important than the cosmesis. And the patient requires multiple surgeries, which cannot be done through a small incision. Therein, we still go through a conventional approach. When you are forcing yourself through a small incision, doing multiple things at a pass, then you land yourself in a complex problem. And then every patient, we tell that there is a risk of a conversion. That means that you go ahead with a less invasive option, but sometimes the anatomy is not very suitable. Sometimes you experience situations which is not seen by the preoperative test. In that case, keeping the patient safety in mind, we still go for what is called as conversion. Though we start with less invasive, in 1%, less than 1% cases, we stop the procedure midway and we go for a conventional approach, because the patient safety is the bottom line. So, as I said, less invasive is not the goal. Our goal is to do a proper long-term performed surgery. And less invasive is only the approach to do the surgery. And that is only done for improving the patient's short-term outcome. When you cannot achieve a long-term outcome, less invasive is not the goal, right? So the bottom line is the patient selection is more important and the patient safety is more important. Only then you select the right operation for the right patient.
Right. So when we speak so much about these new techniques which have evolved over the last few years, I'm sure there is some kind of a training and a practice that is required. So Dr. Adil, what kind of mindset and skill evolution is required for surgeons transitioning to minimally invasive or robotic cardiac surgery?
Well, Sneha, just as you know, the theme of the show is treatment zaruri hai if there is a problem. If you want to do robotic heart surgery, commitment zaruri hai. And I cannot but quote the adage, you got to learn to crawl before you learn to walk. And you got to learn to walk before you can run. And robotic heart surgery is something like that. You need years of practice to actually get adept and comfortable in doing open heart surgery, progress to minimally invasive surgery, and then finally come to doing robotic heart surgery. And why is that so? Because in case you have a problem with either one of them, like suppose you have a problem with robotic heart surgery, you would need to fall back upon minimally invasive heart surgery or fall back further on an open conventional heart surgery during the same procedure. So I think the skill building is essential. There is a learning curve. It's like learning a new language, but with technological advances, with clinical outcomes and results for patients. So they go as years of training. There are simulators, there are ways to go and practice, but it requires commitment, it requires time. And in robotic heart surgery, it's not a one-man show. Yes, one person is sitting at the console of the robot, a fancy-looking thing, but it's teamwork. It's teamwork right from the bedside assistant to the anesthetist to the nurse to everybody involved in that operating room. And that's what requires success. That's what requires skill, and that's what a success story is all made about.
Right. So that's how the surgeons kind of prepare for it, years of work and all of it. But when it comes to patients, Dr. Arul, I've heard two extreme cases of patients. One who is really scared of all of these new technologies and says, I want to go with conventional, I'm really scared. And there are others set of patients who say, this seems to be very attractive and seems to offer a lot of options. So I want to go for only minimally invasive or robotic. So when it comes to the patients, Dr. Arul, when there are so many options, I'm sure that it's difficult for patients to take a call as such and choose one of them. So how do surgeons help patients make informed choices when multiple surgical options exist?
Yeah, I think when a patient first comes to us with a problem requiring a cardiac surgical solution, we tend to sit down with the patients and look at all the details that are presented to us and have a frank discussion with the patient and the relatives, saying, look, these are your options. You have a minimal access / robotic option. You are a candidate for this. Or simply you're not a candidate for this, you're a candidate only for conventional surgery. And I think this is what is crucial. Clear communication is essential. You got to get it out to the patients there that either you fit into this group or you don't fit into this group. And you got to realize that when you do surgery with these smaller incisions or with the robotic approaches, your zone of comfort is much lesser. You have that much less area to commit even a minor mistake. You've got to be perfect. And sometimes this is surgery, like my other colleagues have mentioned, like Dr. Adil mentioned, Dr. Sudarshan and Dr. Kumaran mentioned, there are certain cases where we are obliged to convert from these less invasive approaches to a conventional sternotomy approach. And we have got to make the patient cognizant of the fact that there exists a possibility of this conversion. Like Dr. Sudarshan, to hop on what you mentioned, this happens in less than 1% of patients. But I think that message getting out there is pretty important because that is what is going to build the ethos of the physician-patient relationship. And that's what outcomes depend on, because at the end of the day, you've got to tell them, I'm doing this for your good, a minimal access / robotic approach. But at the end of the day, what matters to me is your immediate outcome and your long-term outcome. I'm not going to compromise on that. If for some unforeseen reason I'm not able to get it done the way we plan to do it, I'm going to fall back on old school techniques and give you the best operation that is possible in my hands. And I believe that is quite essential. And once the patients are convinced of that, I think they're more willing to go ahead with procedures, trusting the physician rather than give one blanket statement saying that I'm going to get the job done through this and only through this. I think a patient-physician discussion, which is quite frank and open, exploring all possibilities, is essential before we take anyone down that path.
So when we talk about surgeons being prepared or the patients being counseled for it and all of it, we also understand that these new techniques need a lot of technical advancements and infrastructure at the hospital level. So Dr. Kumaran, can you explain us how important the infrastructure is at the hospital level for the skill to develop or to take up these surgeries? How important is it?
See, one thing I want to emphasize is like how important is the expertise of a surgeon the importance is equally given to the infrastructure of the institution or the hospital where this is going to be performed. The infrastructure plays a huge role. Infrastructure in the sense like it doesn't mean like the luxury, the way that it looks like the teamwork, the team involved in this like cardiac surgery thing, which involves the anesthetist, a cardiologist, and other most important things are the bedside assistants and the intensive care unit and everything. These all form as a teamwork, and which also it includes the main thing is the infrastructure of the thing. So, like as initially I told, like it's not the expertise of the surgeon; it's all the expertise of all the entire teamwork, including the anesthetist, the perfusionist, the intensive care, the cardiologist, and most important is the imaging or the radio cardiac imaging specialties. So it's all forms an entire team, and which is very important to have a very good outcome. When it comes to the robotic or the minimal invasive, like the anesthetists, they play a very important and crucial role. Like where we sit in the console and we operate, but the other things are taken care of by the anesthetist and the perfusionist and the bedside. So infrastructure includes the teamwork, which is very important.
Right. Right. So when we talk about the infrastructure, the hospitals also have to take up a lot of processes. They have to approvals and all of it to build up these infrastructure as such. So, so Dr. Adil, could you tell us how should hospitals responsibly integrate robotic programs into their cardiac services? How should they go about integrating it?
You know, Sneha, what's interesting to note is however fancy it may be sounding, every hospital would love to have a robotic technology involved, but that's not the truth. I think any truly good program should evolve organically. And a robotic program in an institute should evolve functionally and organically over time and not be driven by market forces or economic advantages or just competitor changes that are happening in the market. So I think that stress shouldn't be on training the teams, training the surgeons, training all the personnel involved, and then also in research and development. When this happens, when that commitment to getting better patient outcomes is what is fixated, eventually robotic surgical programs are going to be setting in. And it's not just about robotic cardiac surgical programs, robotic cardiac programs, in multi-tier specialties. It could be general surgery, it could be urology. And, I think it's very essential that if you're all sailing in the same boat, the hospital should understand that not just one specialty, all specialties need to be paid attention to, groomed, and organically have that particular, specialty grow in robotics.
Right. So when we speak about minimally invasive or robotic, anything, all of these new techniques, not just new techniques, everything else also, there's a lot of discussion about the cost when it comes to medical expenses. People are really worried that it could be a financial burden. They're not sure if they can kind of get so much of money to spend on it and all of it. So one thing, Dr. Sudarshan, if you could tell us, how should the robotic surgery cost be viewed in a real world Indian context? What are the outcomes that it will give, and how should it be seen as?
Yeah, that's a very important question, Sneha, because after the initial discussion of the advantages and the improvement of the minimal access and robotic surgery, the first thing the patient comes with, what is the cost of the surgery? This is primarily because most of the patients are paying out of the pocket. It is still not covered under many of the insurances because it is still deemed a high-end surgery. I think we are going way forward, and many of the insurance companies are adopting these technologies. But even at this point of time, only I can say maybe 20 to 30% of insurance companies are covering the cost. So the most of the cost of paying patients are paying out of the pocket. Now, the initial costs are definitely higher because the hospital has to procure the robot. The hospital has to pay for the disposable and the instruments. They have to pay for the training of the team. And initial operating times when they start the robotic surgery, it is definitely higher. So if you include all the costs, definitely the patient is paying out of the pocket for this premium cost. But if you look at the overall outcome, the patients are paying for the value, not the expense. The advantage is what the patient is getting. The patient is getting out of the hospital at a much quicker time. The patient is not having much complications like blood transfusions. Patients paying less for any antibiotic which he would have got any infections. And most importantly, the patients are not out of work for a long period of time. Earlier, the patient would be out of work for at least 4 to 6 weeks time. But with the advent of robotic heart surgery, patients are back to work in 2 weeks time. So if you look at all the factors into account, it's definitely not much costlier. Though the initial cost is much higher, but when nowadays the patient gets better and it overcomes all the costs.
Right. So if you look at it in a long term, the cost is also balanced out, is what you think.
Exactly.
So when we see about the cost, I would also like to ask Dr. Kumaran, there are various parameters, I'm sure, that you use to determine how effective the procedures have been and all of it. So when it comes to comparing the outcomes of minimally invasive surgeries and conventional surgery, what truly matters in the long term, doctor? What is it that matters for the patients in long term, or what is it that you see?
Yeah, so good question, Snega. That's the most important thing. Like as a surgeon, we have to explain the patient like what to expect in the long term. It's not like there are many patients, they come and ask me like, can we go about with the robotic or minimally invasive surgeries? What will be the future? So the most important thing is like to have a very good long-term outcome. The couple of things are very important. When you take, for example, a valve repair or replacement, the durability of the valve repair. For example, like if you can convince a patient like, yes, the valve repair is going to be durable for 10, 15 years, yes, that's a good option. But whereas like if you do a minimally invasive and a robotic cardiac surgery and where you're not confident to give a good valve repair and the patient comes back in a couple of years, that's not correct. The same thing which goes for CABG, also coronary bypass grafting. If you can have a durable or complete revascularization and giving a long-term patency of 15 years, yes, that's a good thing. So basically, like the myth is like the minimally invasive and robotic surgery, everything is small, small, small. It's not that. The myth is that's only the approach is smaller, the approach is smaller, the incision is smaller, but what we do inside is exactly the same thing like what we do in a conventional sternotomy approach. When you can replicate what the conventional things through a smaller incision, through the robotic, yes, it's a good outcome. So basically, the outcome depends in patient selection. So if you choose a patient and if you do it right for the right patient, for the right time and the right thing, then yes, the outcome is excellent and it is equivalent to the conventional sternotomy.
Right. So we've talked about from choosing patients to surgery techniques to all of it. So to talk about post-op care and all of it, Dr. Arul, could you tell us how have enhanced recovery pathways reshaped post-operative cardiac care?
Yeah, I think since we're dealing with this entire minimal access robotic ballgame, this is a very important thing that we're touching upon. It makes no sense to do a fantastic surgery through a small incision. Patient is expected to get discharged in 2 or 3 days and back on his feet in 2 weeks without talking about what we call as ERAS. It's a short form. It means enhanced recovery after surgery. I think it's the norm in most cardiac surgical centers these days, most of the high volume centers. ERAS is a multidisciplinary approach that aims at providing and bundling the best practice interventions and therapies throughout the perioperative encounter. So to break it down, when the patient first approaches you, you start assessing the patient from top to bottom, starting with his nutritional status, and his lungs and things like that. Because we're operating on the heart, we've got to look at his lungs, his functional mobility. If we find that those things are, not that great, we send them to the nutritionist, the physiotherapist, the pulmonologist, get all that worked up. Then we take them to surgery. Through the surgery, immediate post-operative period, we again have the anesthesiologists and the pain team taking care of the pain issues, because you got to realize that the major factor that is going to affect the recovery after surgery is how soon the patient is ambulant. It makes no difference if you operate on a patient using all these advanced techniques and he lies down in bed for 2 or 3 days. That's just like conventional surgery. The goal of surgery these days is get them mobile, get them on their feet, get them out as quick as possible. And that's where all these ERAS pathways come in. So you have a multidisciplinary approach, nutritionist, a pain intensivist, an anesthesiologist, the surgeon coming and giving his inputs, the physiotherapist coming, the nurses in the post-operative room encouraging the patient, saying that things are good, get on your feet, get going. I think that's what ERAS and the new age cardiac surgery with all these fancy techniques is all about. It's not just operating, it's about looking at the whole thing. And ERAS is here to stay. And I think it's very, very, very important. I mean, I'm sure that in all the hospitals that we work in, we practice this actively. And I think the structured approach has improved outcomes across not just cardiac surgery, but all other specialties too.
Right. On the similar lines, Dr. Sudarshan, why do minimally invasive and robotic surgeries integrate particularly well with enhanced recovery protocols?
Well, as Dr. Arul mentioned that the adoption of minimal access and robotic surgery adds less tissue trauma to the chest. Earlier, we would cut through the bone and do the same surgery, which would involve lot of traction, lot of pulling and looking at the structures. But now with the added precision of the minimal access and the robotic, we do the same surgery with enhanced precision. So there's less trauma to the tissue and the surrounding structures, which results in the less pain of the patient, less bleeding during surgery. So when there's less bleeding during surgery, we mobilize the patient much earlier. So what has these two technologies like minimal access and robotic has given is improving in the patient outcome. So not only the surgery as well as to do the robotic surgery, anesthesia techniques have evolved, and every patient has to go through the post-operative period like a physiotherapist, as you rightly mentioned. The patient are mobilized much earlier because of the less pain, because of less complications, and because of requiring any less hospitalization. So when there's less tissue trauma, the patient gets mobilized, and that's when the patient recovery becomes much faster. So earlier, mainly because of the tissue trauma is much lesser in minimal access and robotic cardiac surgery.
Right. So that brings us to the end of the discussion. I think we've touched upon all the important points that included in these techniques. So any final thoughts that the doctors want to present, that would be, we can take that.
Sure. So if I may add and probably give a kind of an end note as well, I feel that cardiac surgery today is at the same horizon that laparoscopic surgery was 20, 30 years ago. If 30 years ago, somebody would tell you that they can take out a tumor of the colon or the pancreas laparoscopically, many people would scoff at the idea. But today, laparoscopic surgery is there everywhere for general surgery in tier 1, tier 2, tier 3 cities. It's become a norm. Cardiac surgery is at that same horizon. However, as we know that robotic heart surgery is done at a select few centers across the country and the world today, I think tomorrow holds a brighter promise in future that it's going to become more and more popular simply because of the advantages that it portends. So I think that it's not a competition between open heart surgery and robotic heart surgery, but I think both of them go hand in hand because eventually we want the best for the patient. And I think that technological dominance is not going to set the theme for the future, but it's actually been patient outcomes and advantages. So, from a patient's perspective, it's very simple. If somebody wants to buy a phone today, would you buy a Nokia? Well, think twice. And that's where robotic heart surgery is going to be going to.
Right. Thank you so much, Doctor. Thank you all of you for joining. I know you should be having a very busy schedule. So all of you, thank you, doctors. Thank you for joining us and discussing all of these important topics. I'm sure it is very helpful for the general public out there who want to know how these are going to help, whether it's going to fit for all of them and all of it. Thank you so much, doctors.